Thank you for inviting me to be part of your program. Today, we are going to be discussing cardiac MRI in adult congenital heart disease. I do not have any disclosures. I have several objectives to discuss. The first is to emphasize the role of cardiac MRI in adult congenital heart disease management. And then I would like to focus on some of the more common adult congenital heart disease referrals to cardiac MRI. I'm going to spend a lot of time discussing our care of patients with repaired tetralogy of Fallot, because that may be one of the more common referrals that you see. I will then touch on some of the imaging highlights for patients living with transposition of the great arteries, coarctation of the aorta, and in the last several minutes, I will review how to calculate shunts, specifically when patients have an atrial septal defect. So let's begin. It's important to realize that the adult congenital heart disease population is growing fast. In the United States alone, we know that there are more than 1.4 million adults living with congenital heart disease, and more than 300,000 of them have complex forms of congenital heart disease. And as people get older, their echocardiographic windows are often limited. Therefore, MRI is an attractive modality for long-term surveillance. Here's some data to share with you from our hospital at Boston Children's Hospital, just showing you the age of distribution of patients as they come to our MRI suite. Almost half of them are at least 18 years old. And one take-home point when we're discussing MRI in adult congenital heart disease patients is I always start with some basic principles. That is, it's very important to know the patient's history, to always review prior images, and try to draw out any complex anatomy. We also plan the exam ahead of time to prioritize the goals, and then use a structured approach when we think about the complex anatomy of these patients. So let's start with the number one referral that we get for MRI at our center. That is a patient with repaired tetralogy of Fallot. This is the most common cyanotic heart condition, and in its unrepaired form, it's depicted here, with 4 anatomic abnormalities, varying degrees of right ventricular outflow tract obstruction or pulmonary stenosis, a ventricular septal defect, right ventricular hypertrophy, and override of the aorta. And there are several surgical repairs that patients may have undergone, with the goal of surgery being to relieve the right ventricular outflow tract obstruction and close the ventricular septal defect. You can see that here in this diagram showing a classic transannular patch where the surgeon has cut through the stenotic pulmonary valve and provided a passageway for open flow, also closing the ventricular septal defect. However, some patients with repaired tetralogy may have undergone a right ventricle to pulmonary artery conduit, depicted here. This may be because they had a severe form of tetralogy known as pulmonary atresia, or maybe they had an anomalous coronary artery preventing that classic transannular patch. Both sets of these patients will be fraught with long-term outcomes. When you're imaging these patients, here's some of the anatomic issues that we encounter. Starting on the right side of the heart, patients can get tricuspid regurgitation. They get varying degrees of right ventricular dilation and dysfunction, and varying degrees of pulmonary artery problems, whether that be residual stenosis, regurgitation, or branch pulmonary artery stenosis. The left heart may also be involved, as we know that at least 20% of adults live with at least mild left ventricular dysfunction. There's also aortic dilation and sometimes aortic regurgitation. All of these things we're going to assess by MRI. We know that as patients get older, they're prone to arrhythmias, both atrial and ventricular, and sadly, there is a small risk of sudden cardiac death. So I want to share with you the protocol that we use at Boston Children's Hospital, noting the clock here. And that is, as we care for patients long-term, we don't always use the same sequences every time, but our goal is to get the most important information, recognizing that patients will come for surveillance exams time and time again. Here are some of the techniques that we use. Cine SSFP, we rely heavily on this, looking at 2-chamber, 4-chamber, and short axis views. We do specific imaging of the right ventricular outflow tract to look at that in short axis to help guide decisions for pulmonary valve replacement. And I'll share some of those images with you. We also look at the left ventricular outflow tract and axials for the branch PAs on every first exam. Now for angiography, we often give contrast for the first study, but we have used more and more the whole heart angiogram on subsequent studies, looking at the vascular anatomy. This is particularly helpful in looking at the branch PAs. We do a great deal of phase contrast or flow imaging, such that we look at flow both in the main and branch pulmonary arteries, as well as the aorta and AV valves. Now, if we're giving contrast, we are going to look for late gadolinium enhancement in all first-time studies, and we have now begun looking at T1 mapping for extracellular volume fraction for more diffuse forms of fibrosis. We do this imaging more commonly in those adults that have ventricular dysfunction, and we're repeating that about every 3 to 5 years. There are also some case-specific indications I've listed here where we use other forms of MR imaging to look at specific details. I'd just like to share a few pictures with you. Here's a 3-chamber right ventricular view, as we call it. You can see in this Cine image, here's the right atrium, tricuspid valve, right ventricle here, and as you go out to the outflow, this person does not have much of a pulmonary valve present. You can see some dyskinesis here of the outflow tract as we go to the branch PAs. This is a nice view to start with, thinking about our patients with repaired tetralogy. We rely heavily on the short axis views to quantify the right ventricular and left ventricular size and function. As you can see here, starting at the base and going down to the apex, there's a very dilated, dysfunctional right ventricle. The wall motion of the anterior wall here is somewhat akinetic. And we can quantify, this is a very large right ventricle, by the end diastolic and systolic volumes and a reduced ejection fraction of 36%. You can also see the ventricular interaction that develops in that this patient also has mild left ventricular dysfunction, living with repaired tetralogy of Fallot. Now, I mentioned on our protocol that we usually do Cine axial imaging for all first-time studies. Here's an example of that, starting superiorly and then extending inferiorly. You will note here that you can see the ascending aorta directly behind the anterior chest wall. This is a patient with a right aortic arch. When we look at the pulmonary arteries, you can see the branch left pulmonary artery here more superiorly and the right pulmonary artery. We are able to look for changes in size. We can also estimate with flow calculations the percentage of flow to each lung. We find these images very helpful. When you use gadolinium, you can see differences in branch pulmonary arteries, such as in this patient. This gadolinium reformatted MRA is showing you a small right pulmonary artery. This may be from a prior palliative Blalock-Taussig shunt. Again, we use flow imaging to look at the distribution of flow in both branch PAs. This will help us determine if an intervention would be needed. MRI does a beautiful job looking at the geometry of the right ventricular outflow tract, as shown in several images here. This is that right ventricular outflow tract view where you can see this area of the anterior infundibular wall as you go out to the main pulmonary artery. This gadolinium reformatted image is of a young adolescent whose echo images were somewhat limited, but you can see here that she had a very large aneurysmal right ventricular outflow tract. She went on to have that surgically resected. One of the greatest strengths of cardiac MRI in the patients with repaired tetralogy is our ability to quantify pulmonary regurgitation. Because we know that in the original surgery, that pulmonary valve integrity is often disrupted, leading to significant regurgitation. For younger patients, surgeons have tried more innovative technology to limit the amount of disruption of the pulmonary valve, oftentimes doing more subvalvular resection. But regardless, the majority of patients that you are seeing with repaired tetralogy of Fallot will have significant pulmonary regurgitation. Let's start in this right ventricular outflow tract view here. What we do is we create a plane that is perpendicular to that and generate this type of flow imaging. Here, we can encode color for the direction of flow so that red flow is going out into the pulmonary artery. Blue flow is going regurgitantly back into the right ventricle. And then our computer is able to determine the amount of flow, both forward and backward, to create the pulmonary regurgitant fraction. You can see the calculation here. In our lab, we grade pulmonary regurgitation as mild if that fraction is less than 20%, moderate if it is between 20 and 40%, and severe if the pulmonary regurgitant fraction is greater than 40%. This is a very good technique to use in these patients. This is one area that we really do look at the flow curves, because a subset of patients with tetralogy may have that initial antegrade flow and then retrograde flow is shown here, but late in diastole, they again have signs of antegrade flow. This end diastolic forward flow in the main pulmonary artery is suggestive of having a more restrictive right ventricle. And we know clinically that in patients that have this, they may actually have improved exercise performance. However, some studies have shown us that this is only remarkable at a certain size for the right ventricle. That is, right ventricles whose end diastolic indexed volume is 170 milliliters per meter squared or less. Beyond that, when you get very large right ventricles, the impact of this right ventricular physiology may be detrimental. So I wanted to share with you how MRI helps us with clinical decisions. We have guidelines for the management of patients with adult congenital heart disease. These were published through the American Heart Association and the American College of Cardiology in 2018. And when you look specifically at patients with repaired tetralogy, there is a class 1 recommendation to proceed with putting in a pulmonary valve replacement. It is listed here. That is, in any symptomatic patient with at least moderate residual pulmonary regurgitation. However, many adults living with repaired tetralogy are not symptomatic, so therefore there is now a 2A recommendation that pulmonary valve replacement is reasonable for preserving ventricular size and function in asymptomatic adults with ventricular enlargement or dysfunction if they have at least moderate pulmonary regurgitation. The guidelines go on to present this algorithm here as pulmonary regurgitation severity. Again, symptoms, you would operate. Otherwise, you need at least 2 of the following criteria, and here they are. Mild or moderate ventricular dysfunction, severe right ventricular dilation, and now the guidelines have given us values generated from prior MRI studies showing thresholds where we would consider a pulmonary valve replacement. These are currently an end diastolic index volume of at least 160, an end systolic volume of greater than 80 milliliters per meter squared, or a right ventricle that it's at least 2 size of the left ventricle with regard to diastolic volume. Other criteria for consideration of PVR would include elevated right ventricular pressure or a progressive reduction in exercise tolerance. And it's interesting when you look at patients with tetralogy who've undergone pulmonary valve replacement, you can see this is data from a large meta-analysis just showing you we have great ability to both reduce the amount of PR as well as the right ventricular size. However, the actual procedure has little effect on ventricular function or exercise duration. Interestingly, patients often feel better once they have a new pulmonary valve. And we now have been able to look at data with cardiac MRI to learn more about the remodeling processes of the heart in these patients. That is, although RV size decreases following a pulmonary valve replacement, it will return to its pre-pulmonary valve replacement size by about a decade. Additionally, even though it gets larger, we have not found that right ventricular dilation alone after PVR is associated with poor clinical outcomes. And in fact, in the patients with tetralogy of Fallot, after a pulmonary valve replacement, predictors of poor outcomes would include an older age at the time of their pulmonary valve replacement, a decreased right ventricular ejection fraction after pulmonary valve replacement, or atrial arrhythmias following that procedure. So we are using MRI quite a bit, not only to determine timing, but also type of pulmonary valve replacement. And you will recall in that protocol, I mentioned doing specific imaging of the right ventricular outflow tract. You can see here in these Cine images, we're looking at a cross section of that RVOT here. And what we do is we help determine whether or not a patient may be suitable for a transcatheter pulmonary valve replacement. In our lab, one of the ways to do this is to measure the smallest diameter of that right ventricular outflow tract in the short axis in systole, as shown here. And we need to take into account the relationship of the great vessels to the coronary arteries. MRI does a wonderful job looking at the proximal coronary arteries because we recognize that at least 5% of patients with repaired tetralogy may have an anomalous left anterior descending coming from the right coronary artery. And that may cross right across the right ventricular outflow tract in an area where you would consider putting a pulmonary valve in. This still frame Cine image is showing you a patient with repaired tetralogy who was repaired with a right ventricle to pulmonary artery conduit. And indeed, you can see here as listed, the left anterior descending coronary courses right inferior to that conduit. So you could imagine that putting in a percutaneous valve and inflating a balloon may cause a problem to that coronary. This is one area where we would use black blood imaging to help define the coronaries. You can see in this axial view for orientation, here's anterior, posterior, right, and left. Here's the aortic root with some clockwise rotation. You see the right coronary arising here. Here is the left anterior descending, coursing between a right ventricular to pulmonary artery conduit, which was placed very anteriorly, and a distal dilated outflow tract. We also use contrast on all first-time studies and then try to do that on interval visits, more if patients have ventricular dysfunction. What are we looking for? We know that in areas of prior surgery, there is dense late gadolinium enhancement. That's shown here with these yellow arrows. And yet some patients have areas of fibrosis that's remote from where the surgery was done, as shown in the red arrow here. And that is why the development of T1 mapping and looking at extracellular volume fraction for diffuse fibrosis has been valuable. This graphic is displaying some data done by Dr. Chen showing the degrees of diffuse fibrosis in patients with repaired tetralogy. The right ventricle is depicted in the blue bars. The left ventricle is depicted in the red bars. And Dr. Chen was able to show that patients with more volume overload, such as pulmonary regurgitation primarily, have greater degrees of fibrosis than those with pure pressure overload or a mixed valve disease. We're learning more and more about the mechanisms of ventricular dysfunction and how fibrosis plays a role in our management strategies. Now, as a last point, I wanted to mention there is always a question about how often should we repeat exams in patients with repaired tetralogy of Fallot. And as we go through this presentation subsequently, I will share other data from this document, which is the appropriate use criteria, which was developed specifically for follow-up of patients with congenital heart disease. For those of you that are familiar with appropriate use criteria, the indications are listed as always or green, maybe or yellow, or rarely, which is red. And this is the documentation for repaired tetralogy, routine surveillance every 2 to 3 years in most patients. It may be indicated more than every 2 to 3 years for patients with symptomatic heart failure, and it is always indicated prior to a planned pulmonary valve replacement, either percutaneous or surgical, as I've shown you. Now I'd like to change gears a little bit and briefly mention some other diagnoses that you may encounter in adult congenital heart patients. Let's think for a minute about patients that were born with transposition of the great arteries. That's shown here. The most common type of transposition is known as D-loop transposition. And you can see here that the aorta arises from the right ventricle, and it results in blue blood going directly out to the body. So when infants are born with this form, the most common form of transposition, they cannot survive without mixing of blood. This mixing can occur at one of 3 levels. It can occur at the atrial level in the form of an atrial septal defect or a patent foramen ovale. It can occur at the ventricular level in the form of a ventricular septal defect, or it can occur at the great artery level, such as a PDA. But this physiology is not compatible with living long-term. Therefore, surgical techniques needed to be developed to approach these patients. And when you image these patients, you will need to know, before they go into the scanner, what type of surgery they have undergone, because there has been a progress in the types of surgical interventions for patients with transposition. The classic procedure done in the 1960s is known as the atrial switch. These are defined as either a mustard or a Senning procedure. It's depicted here. The way you can think about it is that the atrial switch allows for the blue blood to get directed directly to the lungs so that it's able to receive oxygen, and when it comes back to the heart, it then goes to the right ventricle, which is still associated with the aorta, but the blood going to the body is now red. The mustard procedure I envision as taking a pair of pants and putting one pant leg up to the SVC, the other down to the IVC, and directing the waste of the pants over to the mitral valve to get that deoxygenated blood to the left ventricle and then out to the lungs. This was a tremendous surgery because it allowed for cyanotic infants to then have good oxygenation. However, we know there are problems long-term, and we look for this with imaging, as this right ventricle was not made to pump to the body. In the late 1970s and 1980s, the arterial switch procedure was pioneered. That was thinking about directing the outflow differently to allow the blue blood as it comes into the right ventricle to directly get out to the lungs through a pulmonary artery, which has been brought anterior to the aorta. You can see in this illustration how there are multiple suture lines as the great vessels have been transected and reimplanted, as well as the need for reimplantation of coronary arteries. This can result in various issues long-term, which we will look at with imaging. And lastly, the group of patients who've undergone a Rastelli procedure would be those that were born with transposition with a ventricular septal defect and pulmonary stenosis. You can see here the Rastelli procedure allows for right ventricular blood to get to the lungs through a conduit, as well as closing the ventricular septal defect in a way that directs the left ventricular blood out to the body. So this will establish, again, normal oxygenation, and yet over time, these surgical areas are prone to problems. I find it helpful to have a list of imaging goals for our patients with various types of congenital heart disease. And here we've listed the various procedures, which I've just shown you, and the types of complications that we will look at with our cardiac MRI imaging. I'm going to show you some examples of these. First, let's start with the oldest set of transposition patients, those that have undergone the atrial switch. Again, this is shown here as the mustard or Senning procedure. Remember, leaving the right ventricle to pump to the body. I should mention that in determining the atrioventricular valves, the AV valves follow with the ventricle. So here, the tricuspid valve is associated with the right ventricle. Here is an imaging protocol that we might use for patients with an atrial switch procedure. We start with that same set of Cine SSFP images, but we oftentimes will do additional imaging, an axial stack, and oblique planes of those systemic venous baffles to get a better understanding for complications such as stenosis or leaks. We do angiography on each study, and again, oftentimes using contrast for the initial study, but then reverting to a respiratory and navigator-gated whole heart sequence to get a better understanding of both the venous pathways as well as the vasculature. We use phase contrast flow imaging to look at flow throughout the main PA and branch PAs, as well as the aorta and AV valves. We often give contrast for first-time studies, again, more often if patients have ventricular dysfunction. And we use black blood imaging if there is artifacts, stents, that we may be able better to see vasculature with that type of imaging. So I'd like to share with you just a few representative images for patients with an atrial switch procedure. Here's a set of short axis views, starting at the base of the heart, going down to the apex. Now again, when you have the most common type of transposition, that right ventricle is still in the correct position, but notice the difference here compared to the patient with tetralogy that we looked at. Here, the right ventricle is large, but it's also significantly hypertrophied. Then when you look at the left ventricle, which we know in this group of patients will pump out to the lungs, you can see that it's much more thin-walled and almost pancaked in its appearance. Quantifying ventricular size and function is important in these patients. We oftentimes include the ventricular mass here in the septum as part of the right ventricle. However you do the analysis, make sure to save your contours so you can refer to them when patients come back for subsequent studies. Here is a still frame reformatted image of a whole heart angiogram, just showing you the venous baffles. Specifically here, it's the SVC coming down. Look how it narrows as it goes into this portion, the IVC pathway being a little dilated. This kind of narrowing of the SVC is the most common if patients are going to have venous narrowing. Oftentimes, these patients are asymptomatic, but this particularly is very hard to visualize by echo. You may see some flow acceleration, but oftentimes patients develop decompressing azygous veins. So looking specifically at these baffles for areas of narrowing can be important. Many of these patients go on to develop heart electrophysiologic issues long-term and need pacemakers. If they have baffle stenosis, that can be a problem with lead implantation. Another complication that we look for in these patients is baffle leaks. So let's start by looking at this Cine image in a patient with an atrial switch. Start here at the inferior systemic venous baffle. You can see that here. The pulmonary venous baffle wraps around it. So here's the pulmonary veins here, and then here, directing the red blood that's returned from the lungs back through the tricuspid valve into a right ventricle that's pumping out the aorta. You can see the hypertrophied systemic right ventricle here, as well as this area of muscle, which is subaortic conus. When we do this type of imaging, we can look for baffle leaks, but oftentimes it's helpful to use our phase contrast imaging here, looking at in-plane flow to see the flow going from the pulmonary venous atrium back into the systemic venous atrium. Here, red flow back into the blue. This is similar to how an ASD would flow. It's important to identify baffle leaks, as we oftentimes will close these prior to implanting any devices such as pacemaker leads, as we run the risk of having clot formation and embolization. Similar to patients with tetralogy, our adults with atrial switch procedure come back on a regular basis for MRI. I point you to these appropriate use guidelines specifically for that. You can see in this column the MRI, which would always be indicated for concerning signs and symptoms. Even in patients who do not have symptoms, every 3 to 5 years for asymptomatic patients, more so if they have hemodynamic residual issues. It can also be helpful in patients with heart failure symptoms more frequently. So let's move on and talk about the slightly younger group of patients living with transposition, those with arterial switch. Just to show again the diagram where the pulmonary artery has been brought forth anteriorly. This is called the Lecomte maneuver. We know that there are long-term complications in these patients as well. You can refer to the imaging goal list that I shared with you, but just to review, because you're pulling those branch PAs forward, they can oftentimes get a little stenotic or stretched right at the proximal area. This again is sometimes difficult to evaluate in adults with echo, and we rely heavily on our cross-sectional imaging. We also know that patients can get degrees of mild, usually supravalvular pulmonary stenosis. This was more common in the earlier surgical experience, but important to look at when we're evaluating that outflow tract. Many patients after the arterial switch procedure are going to get neo-aortic root dilation and regurgitation. We know cardiac MR does a good job evaluating our aortic structures, and we're able to quantify that aortic regurgitation, which thankfully is only severe in about 15% of patients as they reach adulthood. And then lastly, and very importantly, patients can also have coronary occlusions as those coronaries were reimplanted. This is most common early after the surgical experience. However, with our imaging, we're always going to look at not only the proximal coronary artery courses, but also pay specific attention to left ventricular wall motion, ensuring that there are no regional wall motion defects. Here is a typical protocol that we might use for patients who have undergone the arterial switch procedure. Similarly, types of techniques, but focusing on those complications here, we're going to look more at the outflow tracts. Again, when we do our angiograms, thinking about the coronary artery anatomy, we do rely on flows to look at the physiology, contrast in selected cases again, and then case-specific imaging. You'll see here on this protocol, stress MRI when indicated. In the prior versions of the adult congenital heart disease guidelines, stress imaging was indicated at a higher recommendation level for these patients. With advancements in the types of surgical repairs that have been done, this is now a lower level guideline, but should be done on a case-by-case basis if you're worried about ischemia. Just a couple cardiac MRI pictures. Here is a reformatted gadolinium-enhanced angiogram showing you a patient who's undergone an arterial switch. This is the Lecomte maneuver, which the surgeon has taken the pulmonary arteries and brought them anteriorly to that aorta. You can see here, as this swings around, why you might get some proximal pulmonary artery narrowing as those PAs have really been stretched around that ascending aorta. Just again, to reiterate, this type of procedure now allows blue blood to correctly get to the lungs, which allows for the red blood to go to the body through the left ventricle, thus reestablishing the left ventricle as the systemic ventricle. And we again are always looking at the coronary artery origins. Here are just some reformatted images from a whole heart navigator sequence, looking at both the left and the right coronary arteries. The appropriate use criteria are able to give us guidelines for these patients, not that dissimilar in an adult from those with the atrial switch every 3 to 5 years in an asymptomatic patient, more frequent for those that have residual problems, which includes that dilation of the neo-aortic root. Now I'd like to transition and talk about another set of adult congenital patients that you will see. These are those with repaired coarctation of the aorta. You can see depicted here, a classic coarctation really involves a discrete narrowing just distal to the left subclavian artery. However, it's important to realize that when you see an adult with a repaired coarctation, they may not have had a classic form, but may have had varying degrees of more hypoplasia of the transverse arch or descending aorta. It's also important to recognize that there are different types of repairs they may have undergone. I've listed some of them here. One specifically to be aware of is if the subclavian artery was in fact sacrificed to create a better passageway to the descending aorta. That is called a subclavian patchoplasty. In patients who've had this, you will not see the left subclavian directly arising from the transverse arch, but rather it usually reconstitutes distally through collaterals. There are many other forms of coarctation repair. Oftentimes for a discrete coarctation, a surgeon is able to do an end-to-end anastomosis where they disconnect and then reconnect this area. But other times there's more extensive coarctation where they have to use certain types of patch augmentation. More recently in our adults with a native coarctation, we may go right to a percutaneous procedure with a balloon dilation and stent. A protocol for repaired coarctation would be again focusing on that arch. We know that when you're born with coarctation, you are prone to have other left-sided obstructive lesions. Therefore, we take a good look at the aortic root and ascending aorta in short axis, as well as do Cine imaging of the arch in an oblique sagittal long axis plane. Flows may be helpful, and I will show you an example of that. Again, contrast and case-specific imaging. This reformatted gadolinium enhancement image is just showing you a patient who had originally undergone a patchoplasty for coarctation. When you use Dacron patches, these are subject to becoming aneurysmal. And again, oftentimes echo cannot see this area well, so this is where our MRI can be incredibly useful. Here's a list of imaging goals for coarctation, focusing on the arch, but also recognizing those other left-sided obstructive lesions, looking specifically at the aortic valve, recognizing that at least 50% of patients born with coarctation may also have a bicuspid aortic valve. That would lead to varying degrees of ascending aortic dilation. The increased afterload can cause havoc on the left ventricle, causing increased mass, and always evaluating for other obstructive lesions. Just one point about the flow in the descending aorta. This was work done by James Nielsen some years ago, but I think it illustrates nicely when we look at flow what we would like to see in the descending aorta, that normal flow profile with a brisk upstroke, downstroke, as you can see here, or an abnormal profile where it really is blunted. You have this long area of descent, and that would indicate some degree of residual obstruction. So take a look not only at the numbers when you do the flow, but also at the patterns, because it can reveal the interesting physiology. Now, in the last several minutes, I wanted to touch on another use of cardiac MRI in our patients, and that's to quantify the degree of left to right shunts. When you think about left to right shunts in patients, we think about shunts such as an atrial septal defect, which is common. It's depicted here in this picture, allowing blood flow from the left atrium back to the right atrium. And when you think about the physiology, as that blood flow enters the right heart, you're going to increase the size of the right heart. So the classic teaching is that the ventricles will dilate distal to the shunt. These patients almost always have normal systemic arterial saturations. But many times it's a question when you diagnose an adult with an ASD, what is the hemodynamic significance of it and should it be closed? So it's here that we use cardiac MRI to calculate a left to right flow assessment, or a QP to QS. Now, just to review, what is the QP? It's the amount of flow that gets to the lungs. That is, you look at downstream to the entry of the shunt into the right side and upstream to the exit of the shunt from the left side. So in a patient with an ASD, I would use the pulmonary artery flow to start. Whereas the QS is going to be that vessel with the lower flow. So this is downstream to the exit of the shunt from the left side and upstream to the entry of the shunt to the right side. Why do I go through all of this? Because you not only can use your aorta as a surrogate for the QS, but you may find other flow analysis helpful, such as adding in the superior vena cava to a descending aortic flow. That is also a commonly used source for QS. When you think about these shunts, it's important to recognize that an atrial septal defect, being above the tricuspid valve, usually loads the right heart, whereas the ventricular septal defect, or a patent ductus, being below a tricuspid valve, is more often going to load the left heart structures. And the one teaching point that I will leave with you is when you think about flow dynamics, they need to make sense. As we do these numbers, you can actually create a graphic where you're putting in the amount of inflow to the right heart, the stroke volume, and the outflow, comparing that to the left side. And I encourage you to write these down as you're working through your flow dynamics. I enjoy imaging patients with atrial septal defects, recognizing that there are several types. And this is something that you may discover in an adult for the first time. The most common type of atrial septal defect is depicted here as a secundum atrial septal defect. That really is in the middle of the atrial septum. Less common defects are shown here, a primum defect, This is the one that almost always involves a cleft in the mitral valve, or even rarer, the sinus venosus defect, which is almost always associated with partial anomalous pulmonary venous return. But this is not a true defect in the atrial septum. It's very posterior. I wanted to just show you an example of how MRI is helpful in quantifying atrial septal defects. So here would be the classic secundum type in this Cine image. You can see a dilated right atrium and right ventricle, that atrial septal defect. And now I can measure the flow in the main pulmonary artery, shown here in yellow, and compare that to the ascending aorta. You see the calculations here. This shunt fraction is 1.74 to 1, which in general, we would say with right heart dilation is something that we should consider closure. Always making sure there's not signs of elevated pulmonary vascular resistance, which is rare but could occur. But this type of hemodynamic assessment is very helpful. I also wanted to share with you that MRI does a very good job identifying defects in adults that are sometimes very hard to diagnose with other methods. One of the classic ones is the more rare type of atrial septal defect called a sinus venosus defect. To do this, we use a set of axial images. Here we're starting superiorly, going inferiorly, and I've labeled some structures to help us. Here's the right-sided superior vena cava here. And the first thing you notice is that the right upper pulmonary vein is draining directly to that superior vena cava. As we continue to go inferiorly, focus on this superior vena cava into the right atrium, and here you'll see this red arrow is pointing to a dropout of the back wall of the superior vena cava. And in fact, this is the sinus venosus portion of the heart. As you go more inferiorly, that you then see the right lower pulmonary vein coming in normally to the left atrium. But this type of shunt in the posterior wall of the atrium, sinus venosus defect, can cause a significant hemodynamic load and be discovered for the first time in adults. Here's an example using flow imaging to show you flow down the SVC is blue into the right atrium here. Here you can see some of the flow from the sinus venosus defect that's actually being directed into the SVC, and yet some that's actually transversing back over to the left atrium. This was an adult with higher pulmonary vascular resistance, such that she had mild degrees of pulmonary hypertension. You can see this physiology with MRI. So it's there that I'd like to stop and just summarize. I hope I've relayed to you that cardiac MRI is an important imaging modality for adults with congenital heart disease. It really is important to know as much as you can about the patient's history prior to them entering the magnet. These patients come back for serial exams. They want to be as efficient as possible and to get the best information. So for that, I really do try to develop an imaging focus for each exam. You don't have to do every sequence every time, but by doing these sorts of exams, we're able to follow patients longitudinally and even help impact the timing of subsequent interventions. I thank you all so much for your attention, and specific thanks to all my colleagues back here in the team in Boston. I look forward to this symposium. Thank you.